Podcasting from beautiful Sydney, the city of Opera House, Darling Harbour, Blue Mountains, and beautiful beaches. This is ICU Primary Prepcast, a monthly podcast about physiology and pharmacology in intensive care.
Hi, I'm Maddi.
Hi, I'm Swapnil. And today is our special episode. This is the end of year episode. Also, all of you are heading in the festive season. So first of all, wish you all Merry Christmas, Happy New Year.
Yep, have a safe and happy holiday.
Great. Today we are going to discuss cardiovascular physiology part 3. And in this one, we are really going to discuss a lot of basic stuff about the cardiovascular physiology and some peripheral circulation. So Maddi, can you define what is mean arterial pressure?
Sure. So mean arterial pressure is the average arterial pressure during a cardiac cycle and is cardiac output multiplied by the total peripheral resistance. Mean arterial pressure is thought to be important for tissue perfusion, as organ blood flow autoregulation, with the exception of the left ventricle, is generally thought to depend on mean arterial pressure rather than the systolic or the diastolic pressure. It can be estimated by the diastolic pressure plus the pulse pressure divided by 3. Mean arterial pressure is mainly determined by peripheral resistance. It is not altered by damping of transducers and is independent of the site or technique of blood pressure measurement. However, the ideal mean arterial pressure to target within the ICU is unknown, but we generally target a minimal mean arterial pressure of 65 to 70.
That's right. And I think you made a very important point there because it's not dependent on damping of transducer. And that's why we always go by map in ICU. The reason 60 is usually the cutoff is because to maintain the coronary circulation, because at that particular map, you maintain the coronary perfusion. And I think that's where that cutoff comes from. But again, you're right. There is no strong evidence as to why we aim for 65 to 70, or in hypertensive, we aim for 75 in order to maintain the renal perfusion. So yeah, those targets vary in ICU depending upon the patient. And what is the pulse pressure?
So the pulse pressure is the difference between the systolic and the diastolic blood pressure, and it's normally about 40 to 60 millimeters of mercury. The systolic pressure is the maximal aortic pressure following ventricular ejection, while the diastolic pressure is the lowest pressure in the aorta, which is just prior to the ejection of blood from the ventricle into the aorta. The pulse pressure depends on the aortic compliance, that is the change in volume for a given change in pressure. The aorta has the highest compliance within the arterial system, therefore can dampen the pulsatile output from the left ventricle and reduce the pulse pressure. Pulse pressure is generally proportional to stroke volume and inversely proportional to aortic compliance. Causes of widened pulse pressure include age, atherosclerosis, aortic regurgitation, high output states such as fever, pregnancy, and hypothyroidism, AV fistulas, patent dysarteriosis, and thiamine deficiency. Causes of a narrow pulse pressure include hypovolemic and cardiogenic shock, aortic stenosis, and cardiac tamponade.
Thanks, Maddi. Now, in ICU, one more thing that we monitor along with cardiac output or cardiac index is also pulse pressure variation in patients with shock. Can you describe that concept, please?
Pulse pressure variation is a percentage which is calculated by taking the maximum pulse pressure, subtracting the minimum pulse pressure, and dividing this by the mean pulse pressure over a respiratory cycle and multiplying this by 100 to get a percentage. It relies on the premise that pulse pressure is proportional to stroke volume. During mechanical ventilation, inspiration normally causes an augmentation of left ventricular stroke volume and an increase in arterial blood pressure, while expiration results in decreased stroke volume. So therefore, pulse pressure, just while mechanically ventilated, is usually maximal at end inspiration and minimal at end expiration. Patients who are higher on the Frank-Starling curve will have less change in their pulse pressure with the changes in volume that occur during this respiratory cycle. Therefore, a pulse pressure variation of greater than 12% is thought to suggest volume responsiveness. However, there are some preconditions that need to be met in order to use pulse pressure variation. Patients must be in sinus rhythm, be intubated and ventilated with no spontaneous respiratory efforts, have no significant changes in their chest wall compliance, such as an open chest, and have adequate tidal volumes, which is usually thought to be 8 mils per kilo.
That's right. And I think those preconditions are really important because if you're trying to interpret pulse pressure variation without meeting those, it won't be accurate. So that's a very important point. And that's why a lot of monitors doesn't give accurate results. Now, can you please outline the role of vasomotor center and the autonomic nervous system in the regulation of blood pressure?
The vasomotor center is located within the reticular substance of the medulla and the lower third of the pons. It transmits parasympathetic impulses through the vagus nerves to the heart and sympathetic impulses via the spinal cord and peripheral sympathetic nerves to the vasculature. There are 3 important areas that have been identified within the vasomotor center. A vasoconstrictor area, which is in the anterolateral upper medulla, which excites preganglionic vasoconstrictor neurons in the sympathetic nervous system. A vasodilator area located in the anterolateral lower medulla. These neurons project to the vasoconstrictor area and inhibit this area, thus resulting in vasodilatation. Sensory area in the tractus solitarius in the posterior lateral medulla and lower pons, which receive input mainly through the vagus and glossopharyngeal nerves, and then help to provide reflex control of both the vasoconstrictor and the vasodilator areas. As blood pressure is dependent on cardiac output and total peripheral resistance, the vasomotor center and autonomic nervous system can regulate blood pressure via effects on the vessels and effects on the heart. Normally, there is ongoing impulses from the vasoconstrictor area of the vasomotor center, which maintains baseline sympathetic tone of the vessels, helping to maintain normal blood pressure. All blood vessels, except capillaries and venules, receive motor nerve fibers from the sympathetic nervous system. The fibers to the arterial vessels change the resistance, and the fibers from the veins change the capacitance, and thus the volume of blood in the veins. The arterial vasculature is densely innervated, whilst the veins, with the exception of the splanchnic veins, are less innervated. Sympathetic stimulation results in arterial and venoconstriction. Arterial constriction increases total peripheral resistance, thus increasing blood pressure. Constriction of the veins displaces blood out of large peripheral blood vessels and back towards the heart, thus increasing preload and contractility via the Frank-Starling mechanism, and thus resulting in an increase in blood pressure. The lateral portions of the vasomotor center transmit impulses through sympathetic nerves to increase heart rate and contractility, whilst the medial portion of the vasomotor center sends signal to the dorsal motor nuclei of the vagus nerves, which transmit these impulses via the vagus to the heart and decrease heart rate and contractility. There is normally a baseline amount of vagal input to the heart, which maintains vagal tone. The vasomotor center also receives input from other areas of the brain, including the reticular substance of the mesencephalon and diencephalon, the hypothalamus, and the cerebral cortex, including the motor cortex, the temporal lobe, the amygdala, and the hippocampus. These areas can either stimulate or inhibit the vasomotor center and thus affect blood pressure. It also receives input from baroreceptors, affected directly by changes in carbon dioxide and oxygen level. Nervous control of blood pressure is rapid and able to act within seconds.
Thanks, Maddi. This answer needs a lot of diagrams, so I will include all the diagrams in the show notes, which you can access on the website www.critcareedu.com.au. In the last part of the answer, you mentioned about the baroreceptors, and baroreceptor is a very crucial concept, especially from the primary point of view and often asked in the exam. Can you please explain the role of baroreceptors in the control of blood pressure?
Baroreceptors are spray-type nerve endings that lie in the carotid sinus and in the aortic arch. They are important for the acute and rapid control of blood pressure and achieve this via a negative feedback loop. A rise in arterial pressure stretches these receptors, thus increasing their firing rate. These signals are then transmitted to the medulla and the vasomotor center, which feedbacks via the autonomic nervous system to reduce blood pressure due to a decrease in peripheral resistance and cardiac output, like we've already discussed. The carotid baroreceptors signal is transmitted through Herring's nerve, which is a branch of the glossopharyngeal nerve, which then synapses in the nucleus tractus receptor signal is transmitted via the vagus nerve to the nucleus tractus solitarius. The carotid sinus is quantitatively more important than the aortic baroreceptors in regulating arterial blood pressure, as they are more sensitive and respond to systolic pressures between 60 to 180 millimeters of mercury, whereas aortic baroreceptors generally operate at thresholds or pressures of approximately 30 millimeters of mercury higher. The baroreceptors are more sensitive to a rapidly changing pressure and to a sudden decrease in blood pressure, so are important in maintaining relatively stable blood pressure during changes in posture. They are also sensitive to changes in the mean arterial pressure. Under normal conditions, baroreceptors exert a constant inhibitory influence on sympathetic outflow from the medulla. When the blood pressure drops, this inhibitory influence is released, and there is an increase in sympathetic activity, resulting in vasoconstriction, increased heart rate, and positive inotropy, leading to an increase in blood pressure. Baroreceptors adapt to sustained changes in blood pressure. So in chronic hypertension, their threshold resets to maintain this elevated rather than normal blood pressure. Therefore, they do not have an important role in long-term blood pressure control, but are crucial for the acute control and rapid adjustments in blood pressure that occur during the course of the day.
Great. Now, let's switch to peripheral vascular resistance. And that's very important in ICU, as well as most of the patients. We try to control peripheral vascular resistance by administering the vasopressors. So what is peripheral vascular resistance, and what are the factors that affect peripheral vascular resistance?
Resistance is equal to the change in pressure divided by the flow and can be mathematically expressed by the Hagen-Purcell equation, which states that resistance equals 8 times the viscosity of the fluid times the length of the tube divided by pi multiplied by the radius to the power of 4. Consequently, any small changes in vessel diameter result in large changes to resistance, as a halving of the radius will increase the resistance 16 times. The Hagen-Purcell equation does not apply perfectly to the vasculature, as it assumes long, straight blood vessels, a Newtonian fluid, which blood is not, and laminar flow. Laminar flow is characterized by concentric layers of blood moving in parallel down the blood vessel, with the highest velocity being the blood in the center of the vessel and the lowest velocity along the vessel wall. However, the Hagen-Purcell equation does outline the main factors affecting resistance, with resistance being directly proportional to vessel length, which does not change significantly, directly proportional to blood viscosity, and inversely proportional to the vessel radius to the power of 4. So if we think more specifically about some of these factors, when we think about blood viscosity, whole blood is 3 to 4 times as viscous as plasma, as viscous as water, and plasma is about 1.8 times as viscous as water. Therefore, blood viscosity depends mainly on hematocrit. Increased hematocrit would theoretically increase viscosity and thus peripheral resistance. However, in small vessels such as arterioles, this effect is much smaller than in large vessels. Consequently, changes in hematocrit have relatively little effect on total peripheral resistance unless the change is very dramatic. Viscosity is also affected by the resistance of the cells to deformation, so conditions such as hereditary spherocytosis can increase resistance as the red blood cells are less malleable. It is also affected by the composition of plasma, so increased plasma proteins will increase viscosity. The main factor, however, that affects total peripheral vascular resistance is vessel radius, as small changes in vessel radius result in large changes to total peripheral resistance. The arterioles are the major site of resistance to blood flow. Vascular tone, or the degree of constriction of blood vessels, is determined by the balance between vasoconstrictor and vasodilator influences. Only a generalized vasoconstriction will increase total peripheral resistance.
What are the factors that influence vascular tone?
So factors influencing vascular tone can be divided into systemic and local. Systemic factors can be further subdivided into neural and humoral factors. So neural factors, there is a baseline sympathetic discharge which maintains vascular tone, as we discussed earlier. Sympathetic noradrenergic stimulation results in vasoconstriction, and inhibition results in vasodilatation. Sympathetic cholinergic fibers innervate blood vessels in skeletal muscle, and stimulation causes vasodilation. However, they are only activated by strong emotional stimuli and by the anticipation of exercise. Parasympathetic nervous system is not important for the systemic control of vascular tone. In terms of humoral systemic factors, vasoconstrictors include noradrenaline, adrenaline, angiotensin II, vasopressin, dopamine, and calcium, which are some of the vasopressors that we use within ICU. Decreased oxygen levels also cause vasodilatation, except in the pulmonary circulation. Vasodilators include atrial natriuretic peptide, kinins, substance P, prostaglandins, vasoactive intestinal peptide, increased potassium, increased magnesium, and increased hydrogen ions. Adrenaline actually causes vasodilatation in the liver and skeletal muscle. Increased carbon dioxide has a local effect of causing vasodilatation, but this can often be counteracted by the sympathetic nervous stimulation that is caused by hypercarbia's effect on the vasomotor center. Local factors include myogenic mechanisms and humoral factors. Myogenic mechanism is hypothesized to be responsible for autoregulation. Increased blood pressure is thought to increase stretch on the vessels, which causes the smooth muscle in the vessel wall to contract. Humoral factors include vasoconstrictors and vasodilators. Vasoconstrictor examples include serotonin and thyroxine A2 from platelets, and endothelin, which is released by damaged endothelial cells. Local vasodilators include adenosine, nitric oxide, prostacyclin, histamine, and lactic acid.
Thanks, Maddi. Let's move on to the new topic, which is microcirculation. So what is microcirculation?
So the microcirculation is composed of the smallest blood vessels in the body and include the arterioles, metaarterioles, precapillary sphincters, capillaries, and venules. Their principal function is the transfer of substances between the tissue and the circulation, and this occurs mainly across the walls of the capillaries.
Okay. And can you please briefly outline the forces that result in fluid exchange across capillary membrane?
The capillary wall is a very thin, semi-permeable membrane composed of endothelial cells. Fluid exchange across capillary walls normally occurs via filtration, which is governed by four main forces termed Starling forces. These forces are hydrostatic pressure within the capillary, which opposes the hydrostatic pressure in the interstitium, and oncotic pressure in the capillary, which is largely determined by albumin, which opposes the oncotic pressure in the interstitium. Net filtration pressure is the interaction between these four forces. It is equal to the difference in the hydrostatic pressure between the capillary and interstitium minus the difference in oncotic pressure between the capillary and interstitium multiplied by the reflection coefficient, all multiplied by the capillary filtration coefficient. The capillary filtration coefficient is dependent on the area of the capillary walls and the permeability of the capillary walls to water. Now, the reflection coefficient is a correction factor ranging from 0 to 1, which is due to the fact that a small amount of protein leaks from the capillaries. In the glomerulus, this reflection coefficient is close to 1 due to the impermeability of the glomerulus to proteins, while in the hepatic sinusoids, it is closer to 0, as it is much more permeable to proteins. If the net filtration pressure is positive, it generally results in filtration of fluid out of the capillaries and into the interstitium, with the opposite occurring if the net filtration pressure is negative. It was traditionally thought that the arterial end of the capillary has a positive net filtration pressure, whilst the venous end of the capillary has a negative net filtration pressure. That is, it favours absorption at the venous end. However, it has recently been found that net filtration pressure is positive throughout the entirety of the capillary for most tissues, and that the ultrafiltered fluid actually is not reabsorbed via venules, but via the circulation and is reabsorbed as lymph.
Great. So that's the end of our podcast, but I know our tradition and obviously the Christmas or festive season is not an exception for that tradition. So I'm pretty sure you got some question for me.
I do, and it's Christmas themed.
Great. Yeah, sure. Go ahead.
Okay, so what is the most common illness around Christmas?
Come on. You can't have illness in Christmas time. It's supposed to be a very happy season.
Okay.
So I'm going to give you the answer this time, which probably people are going to like more than your answer. It's called as Santa Mania.
No. It's Jingle Bells palsy.
Oh my gosh, Maddi. That's such a dad joke. No, it's a very good joke. Thanks, Maddi. But I guess this time my answer was at least comparable to your answer.
Yes.
Thanks, Maddi. So thanks, folks. So that's the end of our today's podcast. We'll be back in New Year with another topic. Till then, enjoy your holiday season.
Thanks for listening. See you next time.